Good morning. It's my pleasure to introduce after the break Dr. Ebaa Al Ozairi. So if you can please take back your seats. So Dr. Ebaa is a consultant endocrinologist and the current chief medical officer at Dasman Institute in Kuwait. She has a very rich background. She did her training in the UK and in the US, and not less than the Harvard Medical School, where she did research training at Joslin Diabetes Center and medical education at Harvard. She has many publications, many awards, and the most important, I think, for us as women, she was the first president of the ACE Gulf chapter, and she's currently an active member and the co-chair of the WOF MENA committee. So we are looking forward to hear from her address the current topic of growing obesity and type 1 diabetes and the challenges it holds. Dr. Ebaa, the floor is yours.
Thank you, Dr. Maya, for the introduction. And I would like to thank the organizer for an outstanding organization of this conference. I've been here from the first time, and I've seen how this has grown over the years. So, and a big thank you to WOF as well. So I'm really going to talk today to you about obesity and type 1 diabetes, an area that is very close to my heart. As an endocrinologist, when I was doing my training in the old days, my specialty right from the beginning was obesity. And then I have a special interest in type 1 diabetes. And when I used to tell people I run type 1 diabetes and obesity, everyone looked at me, what's the connection between the two? They're too different. And today really has taken this path more to put it into research and how we can move this forward. So this is the outline of the talk today. We're going to see how we're really going to balance the glycemic control and the weight gain in type 1 diabetes. Is it real? And what is the unmet need for the people with type 1 diabetes? So the incidence of type 1 diabetes. In Kuwait, we're the third highest incidence in the world in type 1 diabetes. In medical school, we learned type 1 diabetes is a disease of northern latitude countries. So Finland is the #1, and in Kuwait, we're now the third highest incidence in the world in type 1 diabetes. And we're the second highest prevalence in the world, or the first, depending on the statistics, in overweight and obesity. So that's in general. So we are leading in both, diseases. And many of us thought the type 1 diabetes are a disease of the young, and they're mainly lean people. They will not have, obesity. But now we know half of the people get diagnosed with type 1 diabetes, in the adult age as well. So it's not a disease of the young population. And if we see the new faces of diabetes and type 1 diabetes, we thought it used to be in the lean, in the young. Now we're seeing it, half of it in the adults. And, at least a third of them are having overweight or obesity. And what we will see, these people will be aging and how we're going to look after them when it comes to elderly and obesity and type 1 diabetes. So let's look first at the prevalence of obesity. Is it real in type 1 diabetes? And this is the work that we have led in Kuwait with the SOFIA group. So we're part of the European Commission now. And we've led this work, to look at what is the real data from Kuwait, European country represented by Belgium, and Mexico as being a very high prevalence in obesity. There is a very little data that you see of matched comparative regions. So we really had to look at both the controls and to look at, the type 1 diabetes. And we have put this, to show you this is real. It just got, published in the accepted in the eClinical Medicine of the Lancet group, and it has shown that you have the obesity is highest in Kuwait in people with type 1 diabetes, with at least 23%. 45% of your people with type 1 diabetes will have overweight or obesity. And also this is real in Belgium and also in Mexico. And then you would really need to take into the relationship of type 1 diabetes and A1C as well. So I hope that I have convinced you the problem is real. and you're gonna see more of it, coming when you're digging down in your clinics. What is the unmet need for the people of obesity with type 1 diabetes? We all have seen the evolving technologies in the type 1 diabetes management, from the discovery of the insulin to what we have today from the hybrid closed loop, in the type 1 diabetes. These advancements have really led to the improved glycemic control. But, what we have faced, there is, increase in weight gain as well. Is this part of the therapy, or is it part of, what is happening? That's what we need to look into it more. What is the unmet need? We have so many guidelines for type 1, for management of obesity, and over the years. And none of the guidelines today address, type 1 diabetes and obesity. So this is really unmet need for the people of type 1 diabetes. They're as if they're excluded, stigmatized. They already have a lot of stigma with having type 1 diabetes, and now you're not even offering any, guidelines of how to manage this. And that's what we really hope with WOOF, we will take this to become the first people who will address type 1 diabetes and obesity. They're not the same as type 2 diabetes. So we've published this, and even when we look at their liver fibrosis in obese, type 1 diabetes compared to people in type 2 diabetes, they behave differently and they're not the same. So they are phenotypically different, and their obesity is a different phenotype as well. So what are the challenges? Most of the literature really focuses on type 2 diabetes, really not addressing your type 1 diabetes. And the therapy that we're giving to people, in type 1 diabetes promotes weight gain. And if you ask them to do any lifestyle, it's almost impossible with type 1 diabetes. If you ask them to exercise, you're proning them to a higher risk of hypoglycemia. If you put them on low, lifestyle modification, if you ask them to go on a low-carb diet, you're increasing the risk of, going into DKAs and into more hypoglycemia. So the balancing act here is very difficult when you compare both type 1 and type 2 diabetes. And, when we know that we get a tight glycemic control, and that's we all know it very well from the DCCT trial many years ago, this will be associated with weight gain of at least 5 kilograms to 6 kilograms of just intensification of your insulin therapy with an increased risk of hypoglycemia. So we have really published in our Lancet, review, what are the factors that will lead, to the pre-obesity, and what are the factors that might lead to the people with driving the weight gain. So we said your therapy is part of it. The duration of type 1 diabetes is highly associated with increased hypoglycemia. And you have the defensive snacking that will increase your risk of hypoglycemia. And a lot of these people are not really happy to exercise as well. So it's the vicious cycle of, giving them insulin replacements, and then you're gonna increase the dose and add on. And it's also what we have been advocating in our education. You can eat, inject, and repeat. So we tell them, inject before 15 minutes, eat whatever, count your carbs, and then repeat as much as you want. So it's also what we have been advocating in our management for the people of type 1 diabetes, has not really led to anywhere as well. So from this, we really wanted to take this further and have put this, our publication, looking at what's the qualitative and what is going under, with the people with type 1 diabetes as well. So from the Lancet review, we have gone to look at how we're gonna navigate this. We have taken this further from our SOFIA work with the European Commission, again led in Kuwait. And what is the real situation of the type 1 diabetes? What is the unmet need for the people? And what is really important when you look at qualitative studies, again, you look, is there any health-related quality of life? And you examine the quality of life in clusters and see what really affects and what is the main area that you want to focus in. So we've done this with health-related questionnaires and with an interview. And you'll see that, all 8 domains of your health-related quality of life were really lower compared to the general population. The only thing that was similar is the vitality. So we can see where are the clusters and what are the things that we need to move forward to. And when we see these people in the clinic, nowadays, all what we're focused on the downloads. So we look at the downloads and we say, yes, what's the time in range? How much is below range? And what is it? And we forget the person in front of us, and we forget to even, ask or deal with overweight or obesity, because probably we're not yet, well trained to take both into actions as well. So, and what we're going to offer these people, when we said lifestyle is almost impossible, what can we go next? And we're leaving this people with type 1 diabetes feeling, I guess it's my own responsibility to deal with it. Thank you, doctor, for telling me. Well done on the time and range, and well done on keeping your glycemic control, and forgetting the patient as a whole. So what about pharmacotherapy in type 1 diabetes? We all learned in medicine, when we prescribe, the first rule, we do not do any harm. So please do not ever prescribe for cosmetic reasons. Do take into actions that with the type 1 diabetes, you have a higher risk of DKA and you have a higher risk of hypoglycemia, and how we're going to manage these when I'm looking after these people. We have seen there has been a plethora of, type 1 diabetes and adjuvant therapy in type 1 diabetes, not addressing obesity. And that's, looking at, from liraglutide to exenatide to dapagliflozins and many others. And we've seen that there has been, a weight loss with the A1C. And the same thing when there has been, a lot of RCTs that are done on SGLT2 as an adjuvant therapy on type 1 diabetes for glycemia, not addressing obesity, but again, you see also the weight loss in there. So this has really led us to look at, and we've published our results. What if we add GLP-1s, SGLT2, and a combination therapy in people with type 1 diabetes, overweight or obese? And this was just a retrospective study from our, clinics. And what we have seen that, if we use SGLT2, you'll have, a weight reduction of almost 4%, and you'll have some A1C reduction as well of equal to 0.4%. When we add both a combination of GLP-1 and SGLT2, you're having at least 9%, of weight reduction and, 0.6% of A1C reduction. So this is really impressive, taking into any therapy that we use in our type 1 diabetes. Because, with the A1C reduction, if we get anything more than 0.5% as an adjuvant therapy in type 1 diabetes, that's real. So then we wanted really to take this into a randomized controlled trial and looking at, how would we take this even further if we combine SGLT2 and GLP-1 in a randomized controlled trial in people with type 1 diabetes, overweight, and obese, and have microalbuminuria. Because today, what is the situation? If we get someone like this, we all say, no, the guidelines does not support us at all, so we do nothing. We wait for their eGFR to deteriorate, their microalbuminuria to deteriorate, and they'll end up in kidney failure and dialysis. And we have nothing to offer them because we're all, worried, of the increased risk. And we have to be worried, but also we have to think there is unmet needs and there's a microvascular complication that is happening. Taking into account your type 1 diabetes have a very high cardiovascular risk and kidney disease and microvascular disease. So the key questions in our trial, and I have presented this in the ESD as well, is combining GLP-1 and SGLT2 in people with type 1 diabetes with a BMI 25 and above, with a chronic disease. Is it safe? Is it additive? And does it improve any outcomes? And if we look at the percentage change in body weight, when you put things in a randomized controlled trial, you see you get different effect to when we have seen in our real-world evidence and in our, retrospective data. And that's why it's important that whatever we do, we really need to do the trials and to really confirm what we have seen in real-world evidence, and what happens when we put people into the trials. And we see that a combination therapy, was almost as equal in GLP-1, but when we added a combination of a lifestyle, that has pushed things more. And then you see what is really effective is the albumin to creatinine ratio. and that is the reductions when we've done both per protocol or intention to treat, and that is pushing you both for, the albumin-creatinine ratio improvement and for weight loss. So this really takes you into the journey of the lifestyles and, pharmacotherapy. Then we move about bariatric surgery in type 1 diabetes. How many of you have seen people with type 1 diabetes who have undergone bariatric surgery? Put your hands up. So there are as many people with the type 1 diabetes going, under bariatric surgery. And, what we have seen is really conflicting results, in real life, because they do not hardly have any improved A1C. So, because they have, increased risk of hypoglycemia. And that is a nightmare, to manage in the type 1 diabetes, even with the new therapies, with a combination, the hybrid closed loop. So the A1C does not really improve the bariatric surgery. Yes, they lose weight, and they have, a huge reduction of the weight. This is associated with a huge reduction of the insulin, dosages. So this is absolutely yes. But we have them at an increased risk of DKA and definitely increased risk of glycemic variability. The minute that I see a patient type 1 diabetes come in the clinic and I see their basal insulin is very low, before I even look at them, I say, they must have undergone bariatric surgery. And then you will see their downloads, and you'll see that they will have a higher risk of glycemic variability for sure, and you'll have this, much harder, difficult to control their hypoglycemia risks. So, the bariatric surgery is something that we should not really advocate in our people with type 1 diabetes. It's, it does not really have any, increased benefit for them from the glycemia benefit. So we have seen what we can offer today to our people with type 1 diabetes. Lifestyle, almost impossible. Bariatric surgery will increase your risk of hypoglycemia and DKA. Pharmaceuticals, and that's the most sad part of the pharmaceuticals. Novo, Lilly are companies who have, introduced the insulin. So they made the insulin. And today, when you come to trials that includes obesity and type 1 diabetes, they've excluded people with type 1 diabetes. And some of the companies even have in the label contraindicated in people with type 1 diabetes. So you made your history by going into the industry and insulin, but today we have a huge unmet need from the people of type 1 diabetes that we are not addressing. Of course, with these medications, you have to use them, carefully, because you do have increased risk of DKA and, hypoglycemia in some cases. So you would need special training for using them, but we have to start addressing the unmet need in our people with type 1 diabetes. And what we have to look at, not body weights, not your scales, not your reporting and data and downloads. Listen to your patients and address what they need from, what is the main stigma part. We have looked into a lot of things, into qualitative studies and how to move this forward. And the words that the people with type 1 diabetes describe is, unbelievable. So we have to think of how we can move forward beyond our medical training of just focusing on what we have always been taught. And here I will also argue that a lot of people would say you cannot have DEXA scans in your clinics. And I would completely argue against this. Because if you're an obesity specialist clinic and you say, I don't have an access to DEXA scan, and we do not look at DEXA scans, or we're just doing BIA, then I tell you that you're not a full obesity specialist clinic. Why dermatologist colleagues and many other endocrinologist colleagues would mandate to have the DEXA scan when they're treating osteoporosis? But when it comes to obesity, we say we cannot afford it. If osteoporosis, you do not start any osteoporosis medication today without a DEXA scan. You follow them up with a DEXA scan. But when it comes to obesity, oh no, we cannot afford it. So this is, not good enough. And I think it's part of us in obesity world that are not pushing this enough, similar to our rheumatologist colleagues. And that's what I would like to see changing in our guidelines. Not saying in a research center if we have access to, because we do not put this for osteoporosis treatment in a research center if we do not have access to it. So we have not been leading the obesity in the right direction, and that's what we should take it forward. So I would like to end up the talk and say we're here to inject hope in our people with type 1 diabetes. They're sick of us injecting them just insulin, so we just need to inject them with hope. The increase in obesity in people, with type 1 diabetes is real. It is unmet need, and there is urgent need to develop a specific guidelines for the treatment of obesity in people with type 1 diabetes. And I would like to thank the whole team back home. And honestly, this cannot be done with the great mentors who have pushed the research career in my life. And I'm very grateful to them, and with a lot of great friends as well, Donna Ryan, Carl Leroux, and many others, and a lot of thanks to our friends around the world. And I would like to congratulate you for seeing how this has expanded over the years, and I'm sure we will move forward with the World Obesity Federation to tackle obesity in a new thinking, listening to our people with obesity. Thank you.
Thank you, Dr. Ebaa, for this very nice talk. And for the sake of time, we can take one question.
Structured education program. So I wouldn't go out and dish them, but we have to really start addressing them.
How you will defend yourself if somebody had a complication like DKA or severe hypoglycemia? You are consenting them aggressively or what?
So for the GLP-1 nowadays, the label does not say contraindication when it comes to tirzepatide and type 1 diabetes. However, with the SGLT2, they're contraindicated. So whenever I'm starting this medication, I always ask the patient to consent. You have to remember, we're putting here not only with type 1 diabetes and obesity, but they have also chronic kidney disease. So your microalbuminuria is increasing. You already have put them on, on ACE or ARBs, and you have nothing else to add. So you'll tell them you're at increased risk of DKA, but if we do nothing, also you're at increased risk, your microalbuminuria will deteriorate, and you'll end up in kidney failure. But it's all documented. You have to say, I have discussed this with the patient, and the patient have to sign a consent. When we have done, it's a trial, so everything is under trial, but also we have our retrospective data.
Regarding the insurance companies, I don't know about Kuwait, but they are approving to use insulin, SGLT2, GLP-1.
SGLT2, you should not use them as routine. And that's what I want to say, because of your increased risk of. But the GLP-1, there is not in the label in the current tirzepatide to say contraindicated, in the label that we have in Europe and in the Gulf. In the US, it is still contraindicated in their label.
Insurance does cover.
Insurance would cover it for obesity. So if you cover it for obesity, it will cover. It will not cover it for diabetes. And that's what you have to be careful about.
Good comment. Thank you.
Ebaa, can I just have a quick comment? I just wanted to have a change of heart on referring them to surgery. And I'll tell you, I've done close to 20 patients in type 1. And the reason we do them is when they have familial history. And usually they have familial history of obesity. And they use insulin in a way, escalating dose, etc. And I'll tell you, the benefit is not for the hyperglycemia. But if you look at the papers, whether by Ali Aminian or by Ranvieri, the problem of DKA happened because the goal of surgery was for them is to reduce insulin, and that shouldn't happen. My first 2 cases had DKA, and afterwards the next cases didn't have it because we changed our target. We're not treating diabetes, and that changed the way we handle the variability. I've done patients on pump as well.
Yep.
We've done even bypass on them,
Yep.
and really, literally, we've reduced that effect. So now I think it's better if you combine your work with an endocrinologist who's smart to understand.
I look a lot after these people. I would say yes, the DKA risk was because both anesthetists and endocrinologists would stop it, but the hypoglycemia and glycemic variability will stay forever, and that's what you have to watch for. I think we're going to take it later.
Thank you so much, Dr. Ebaa. Yes, thank
Another
you.
question, Doctor. Please, another question. Assalamu alaikum. I am Dr. Ala Muyassar, subspecialist clinical nutrition. Thanks, Dr. Ebaa, for interesting lecture. Also, some patient with type 1 diabetes complain of insulin resistance with normal renal function test. So can use a drug for control of diabetes and hemoglobin A1C, and at the same time control of weight, weight loss.
Yes,
also.
so that's what we're saying. Type 1 diabetes and
Yes.
obesity exist. It will lead to increased insulin resistance, and we have to address it with therapy,
With normal renal function test.
even with normal renal function testing.
Thanks.
Thank you so much, Dr. Ebaa, and I'm sure she would be happy to take questions if you have further.